pleased to have two presenters. We are a technical assistance provider in the We Choose Health initiative, and I would like to turn it over now to Beth Seidel, who is our manager for our baby-friendly hospital initiative, and she'll be introducing the presenters. And we're very pleased to have both Brianna Yeager and Melinda Noonan on the webinar today. Thank you.
Thanks, Mary. This is Beth Seidel. Like Mary said, I am the project manager for the Baby Friendly Expansion Grant Project for the Illinois chapter of the American Academy of Pediatrics, ICAP. We are currently working towards Baby Friendly designation by 2016. Today we have a really exciting webinar on the economics of breastfeeding and its connection with the Baby Friendly Hospital Initiative. And I would like to introduce our speakers. We will have two. Our first one is Dr. Brianna Yeager. Dr. Yeager is an assistant professor and research specialist in the Department of Health Systems Management at Rush University Medical Center. She is currently researching the cost effectiveness of feeding premature infants in the NICU and the cost effectiveness related to interventions that assist mothers in providing human milk. She has also developed a series of electronic tracking tools that allow mothers and health professionals to electronically record data during studies for human milk feeding in the NICU. Dr. Yeager also chairs the Breastfeeding Committee for the Maternal and Child Health section of the American Public Health Association. She earned her BA in Organizational Development and Interpersonal Communications from the University of South Florida, her MS in Health Systems Administration from Rush University, and her PhD in Public Health with a concentration in Health Administration and Policy from St. Louis University. She also sits on ICAP's Committee on Breastfeeding. We're very fortunate to have her on that committee with us. She's a very valuable contributing member of that. We also have Dr. Melinda Noonan, who is Assistant Vice President, Hospital Operations and Director at Rush Children's Hospital at Rush University Medical Center in Chicago. Dr. Noonan has held leadership positions at several Chicago area hospitals and academic medical centers over the past several decades. In addition to hospital operations, she held service line administration positions in cardiovascular, oncology, and women's and children's services. Dr. Noonan managed a national healthcare consultant practice for several years, assisting clients with strategic planning and service line development. She has published and presented nationally and internationally on these areas of expertise. Dr. Noonan earned her BSN from University of Illinois at Chicago, her MS in Nursing Administration from North Park University, and her Doctor of Nursing practice from Rush University. I would like to thank both Dr. Yeager and Dr. Noonan for presenting with us today, and we're going to get started with Dr. Yeager.
All right, thank you, Beth, so much, and thank you all for joining us. Today we're going to talk about the economics of breastfeeding and the Baby Friendly Hospital Initiative, and if at any time I know I'm a little bit softer spoken, so if you can't hear me, please let me know, or let them know and they'll tell me. So we're going to jump right in with some, hopefully, there it goes, with some acknowledgments of, there's a lot of work at Rush that happens around human milk, and it's led by our Rush Mother's Milk Club, which is a nationally recognized practice for milk. These are the contributing members of the team that's led by Dr. Paul Meyer, and they contributed to much of what we're going to talk about today, so we just want to thank them for all of their contributions. We also want to acknowledge that the Mother's Milk Club and the work that we're going to talk about today about the economics is part of ongoing work that's been funded by the NIH and previously was funded by ARC and Medela out in McHenry, Illinois. Our objectives today are to go over some of the global economics of breastfeeding for hospitals and healthcare providers, to look at the Baby Friendly Hospital Initiative. We're going to specifically focus on step 6, which is always known as the buying formula step, to look at the costs associated with each type of feeding, and then we're going to end with a case study of our considerations that we've faced in our journey along the baby-friendly application process. So there's a little bit of background, and I know I'm preaching to the choir somewhat, but there are roughly 4 million births annually in the United States, of which 12% of those are premature. What's important about that 12% is they account for about $26.2 billion a year in healthcare and societal costs. So everything from their birth stay on through their early education years where they may require additional social services, it's a pretty expensive group to treat. Within that preterm birth group is the very low birth weight infants, and they're a special population for us here at Rush. They're also a special population nationally. They represent about 1.5% of births annually, but 35% of hospital cost for that initial birth stay. So this is a group that administrators really want to take a look at, a deep dive into, to see how can we control costs, because they are a big portion of it. In order to control costs, you really need to understand what drives it. So during the hospital stay, those short-term drivers are those premature morbidities like brain injury, which would include interventricular hemorrhage and periventricular leukomalacia. I love my words. Necrotizing enterocolitis, late-onset sepsis, and chronic lung disease. And you can see the proportion of infants that are affected by those, and then the marginal direct cost in hospital expenses that those morbidities contribute to. Long-term in that group, that first year of life, 82% increased risk for acute care visits to the hospital, so they're coming back to us. Often they're coming back to us both in our primary care settings as well as in our hospital settings. In fact, the risk for rehospitalization is 25%. Childhood, it's higher, there's neurological and developmental impairment, those social and educational services, and overall higher health costs that actually last well into later childhood or adolescence. So human milk is one potential therapy that can help us to mitigate those costs and go after them, lowering them, bending that cost curve. Human milk is associated with lower risk for morbidities, infections, and childhood illness. It also lowers the risk for those longer-term health conditions such as obesity and diabetes. It is associated with improved neurologic and developmental performance, including things like IQ and performance in school settings. And probably the most important part from a cost perspective is that it's widely available, and it has this real opportunity to be cost effective. So hospitals need to think about, and healthcare providers need to think about, how do we get human milk for our infants? And with term infants, it's a pretty straightforward, simple, maybe simple. I have 2 infants of my own. It wasn't always simple. It needs mom's time. You know, the biggest thing in getting term infants is the mom has to commit to it. You need her time to be able to feed her baby. And for many women, they're, you know, especially modern women, they're juggling a lot of things. They might be working, they might have other children, other commitments. So it is a time commitment that they have to make, and that is something that we as providers need to be cognizant of and respect. With premature infants, it's a little more complicated because these babies are sicker. They're not going to go to breast right away. They require a little bit more. So it starts with a really good hospital-grade breast pump in the hospital as soon after delivery as possible. In order to collect the milk, you need the kit. And again, recognizing with those women, you still need their time. And for our premature moms, they may themselves be sick. So that time commitment that a term mother might face is further complicated for a preterm mother because she herself may have illnesses that require attention as well. In thinking about that time, we also need to think about the financial barriers that moms face. So for term mothers, that financial barrier might be that the insurance company doesn't cover a lactation visit. And we know that the wonderful work that has been done in public health and with health reform in recent years has really opened up the idea that these are visits that should be covered. they're not, it's still something that, the insurance company might offer it, but the employer might not choose it as an option, or it might be one of those things that falls under your HSA or your FSA as an allowable expense. That's a far different thing than this is something that you must do. It's just a different mandate. So they may have trouble accessing the help that they need. For preterm moms, it's again that they might have that same problem with lactation visits, but they also have to come up with the cost of the pump and the kit to rent. The kit oftentimes is buried in the hospital bed charge, but not always. They might have some unexpected costs from having a preterm infant. They weren't expecting to have that baby right away, so they may be going back to work in order to save their maternity leave for when that baby comes home. They might have insurance costs that are far higher, deductible when you have a more expensive birth than a lower. Transportation and parking costs. I know to park at Rush every day for our families with the reduced parking is somewhere around $8 a day, and that still might not sound like a lot, but if you're paying for it every day, all of a sudden it's $40 or $60 a week. It's a pretty big expense pretty fast. And then for these women, insurance does not routinely or universally cover the pump and the kit. So one of the great things about health reform is that it did put back the breast pump as an allowable HSA, FSA cost, or the payment for the rental. And when you look at those, it's awesome, but it's still out of pocket. You still have to pay for it up front and then be reimbursed. Hospitals, knowing all of this, when we look at, okay, what do we do if we don't have human milk from the biological mother? Well, we really have two choices. We can feed donor milk or we can feed commercial formula. And I'm going to take you through some research we're doing now that really compares the cost of investing in the mom to get milk from her versus donor milk or commercial formula. So why this is important for baby friendly is that if we look at step 6, it says that you must give newborn infants no food or drink other than breast milk unless medically indicated. For hospitals, that means some changes in how they allocate their finances. So basically, like the mom, requires a couple of things. First one is you need staff time, and that involves many different steps, which Melinda will go through, from changing policies, writing policies, going to trainings, spending a little bit more time with women who might need assistance with lactation. All of those costs are real costs that you're going to have to pay for in some way. It also requires those policy changes, so removing those pacifiers, getting rid of the routine use of them. That's a pretty big policy change for most medical centers. You also are really increasing that skin-to-skin, and here you can see with our preemies, we go skin-to-skin as soon as the docs say that we can, and that's a really great thing for our families. And lastly, it's a resource reallocation and or investment. So sometimes it's just shifting money around. Sometimes it's actually coming up with new sources of funding to fund new initiatives. So we're going to focus on looking at that newborn infants, no food or drink other than breast milk, and we're going to look at what it costs the hospital to acquire that human milk. All right, this is a study that recently was accepted for publication in the Journal of Human Milk and Lactation, or of Human Lactation, so you can see it hot on your shelves sometime this summer. In its full, you can get the full story. Today we're going to give you the shorter version. It was a cost analysis. We used 3 sources of data: the hospital budget, the infant's medical records, and then here at Rush we have all women complete maternal pumping records. It's a little booklet that we give them, and they fill it out when they pump. They record what they pumped, how long they pumped. It's a way for us to kind of troubleshoot any problems they may have with providing milk for their baby, or to recognize those danger signs of a woman who isn't going to be able to achieve her breastfeeding goal because she doesn't have a high enough volume. The sample is that we used for this particular study was mothers and their very low birth weight infants who were enrolled in that ongoing prospective cohort study funded by the NIH. For my more research-inclined individuals, these are just some of the criteria for enrollment. We looked at only infants admitted within 24 hours of life. birth weight less than 1,500 grams, gestational age less than 35 days, and they had to be fed by day of life 14. And most infants are, but there are some that are not. For the women, they had to be able to provide human milk, so that meant no contraindications. So they must have had a negative maternal drug screen for all drugs except marijuana, and they also must be HIV negative. For the infants, we did require that they survive through discharge so that we could look at the full cost impact to the hospital. We also had to have pumping records that were usable from the moms, so that meant at least a week's worth of logs so we could really see what happened in her pumping. You know, did she come to volume or not? And then more practical nuts and bolts, it had to be decipherable. We had to be able to read what it said. You know, we had one mom who recorded it in a unit that none of us knew what it was. We weren't sure if it was ounces, milliliters, liters, so we had to exclude some of those records. This is who our sample was. Of the 157 women who met all inclusion criteria, there are about 450 women who are in the study overall. We ended up with all 157 pumped for the first 2 weeks. And then after that, you lost some women who decided to no longer pump or whose infants went home, and you can kind of see how those decisions were spread out across the sample. So to really measure what it costs to acquire human milk, we had to look at the daily human milk pump volume, which was the sum of milliliters of human milk pumped from both breasts for every single pumping session during the day. We also looked at average daily human milk volume categories. So we wanted to see where women fell relative to each other, so that if we could establish, what's the benchmark, where, what is the minimum volume threshold that they need to achieve for it to be cost effective. We wanted to look at that, and so we looked at 100 milliliter increments from less than 100 milliliters a day to over 700 milliliters a day. In fact, we had one mom who routinely provided 2,000 milliliters of milk per day. We also looked at containers. This is an expense that is borne by the hospital. We give women a variety of sizes. We decided the most used size was the 120 milliliter size. We used that for the purposes of the study. And it's not an item that we really record well on site, so we did a little estimating to figure out what we would give. So we took the mom's volume and divided it by the number of containers, multiplied that by 1.2 to allow for some overage. Oftentimes our nurses will say, do you have enough containers? Oh, here, let me give you a couple of packages extra just so you don't run out. So we put in a kind of a conservative 20% overage, and then we also always rounded to the nearest value of 3 because the packages come in three containers to a pack. Our cost to acquire human milk was the cost that we as the hospital pay for the breast pump rental. So that's the negotiated price that we pay per pump per month. The pump collection kit, again, that's what we pay to the vendor to have the kit. And then the cost of the storage containers, and those are about 20 cents per container. It's $1 per pack. I'm sorry, 60 cents per pack. I really do teach math for a living. So we had 34,505 pumping sessions across all of our women. Almost 95% of them had complete data. So there was only 5% missing across all of them. We felt pretty comfortable imputing that missing data using averages for that mother on that day that she pumped, or on that day before and after if it was an entire day that was missing. We ran some statistical and some cost analyses. Our cost analyses, the biggest things were we had to identify and measure factors that influence cost. So we went with the kit, the pump, and the containers, because those are the first things that you need to get human milk in the door. You need the mom to provide it to you. We left out some of the other stuff like staff time, lactation care in this study because we thought, well, if she's not giving you milk, it doesn't really matter how many staff you have on site. We wanted to look just at the cost. We also wanted to be able to comparably compare it to the way in which donor milk and commercial formula are procured, and that's, you look at the price and you pay the vendor for what it is. So our donor milk, we do not use donor milk routinely here, but we do study it, and donor milk costs about $14 per ounce, or per 100 ml. We use per 100 ml as the, so 3 ounces would be the value that we use. In commercial formula, we used our prices, which was right around $3 for liquid ready-to-feed formula. So that's the pre-prepared formula for preterm infants. Not too fast. The women that were in our study, they're a little bit older, quite a large portion that are non-Hispanic, African American, or Hispanic. Most receive WIC, and most receive commercial insurance. Our infants, since it's our very low birth weight population, they're predominantly male, birth rate around 1,000 grams, 28 weeks, and the average hospital stay was 72 days. For our pumping characteristics, 50% of our women pumped past the 60th day of life for their infant. 30% of them pumped all the way through discharge. The median number of days pumped was 44. Most women pumped at least 4 sessions a day. They pumped on average around 330 milliliters. And to put that into context, a healthy term infant requires about 550 milliliters per day. We tend to say that in the NICU, at least if you can get them at least over 250 to 350, they will go on to be able to establish a volume that would allow for exclusive human milk feeding. And anything above that is great. So our women are really diligent. They're meeting those standards. They really can provide milk for their infants for the long term. And at Rush, in this population of infants, 90% of them were able to be have all of their enteral feeds equal to human milk. So it's a very high human milk fed population in general. So the important part here is a look at what it costs per day of pumping per 100 ml of human milk. And I put in there the cost per 100 ml of donor milk and the cost per 100 ml of that liquid preterm formula. And what you can see if you look on this graph is that for every single category, even the women who were less than 100 ml per day, they are, that milk you get from them is less expensive than going out and buying it from a donor milk bank. What that says to me as a hospital administrator is, wow, investing in my own women, providing that pump and that kit and those containers for them is cost effective. It's cheaper than buying donor milk would be. If I look at commercial liquid preterm formula, I see a similar pattern. Investing in our moms is less expensive than liquid preterm formula, and we know it's better health-wise. When it becomes less expensive varies by the type, how much the mom is able to produce. I will say that it is, preterm formula is more expensive for every category except that lowest one. So if I'm setting my priority targets, I'm saying, I want all of my moms to pump at least 100 mLs per day, because that's going to allow me to have a human milk is less expensive than both donor milk and preterm formula. And it happens within the first month of life. We're talking about a couple of weeks at the most. In fact, it's day of life 17 or 18 there on the screen, when human milk from the infant's mother is less expensive than formula for that lowest volume group. So it really it happens very rapidly. In the highest group, the women who really are able to produce a lot, it's less expensive than donor milk at 4 days of life or 4 days of pumping, and commercial formula at 6 days of pumping. So it's a very rapid transition. It becomes much less expensive very, very quickly. We did want to see what would happen if our cost structure changed, so we looked at a sensitivity analysis, and you can see that the containers are the biggest driver, so being able to effectively manage and providing women with the right number of containers for them with a little bit of overage is good, because containers are the biggest contributor, and then the pump and the kit follow after that, because those are fixed costs that you pay at the beginning of the month for the pump. The kit is a one-time cost. You pay at the beginning, and they tend to last the entire NICU stay. Sometimes it might get stepped on or broken, but most of the time it lasts the whole time, and it tends to contribute the least to the overall cost. So what we found for our women is that human milk is less expensive than donor milk and commercial formula, provided that the mom achieves that minimum daily human milk volume over 100 ml. This is a real opportunity for us as hospitals, because as long as we can prioritize some resources for those ladies to get them over 100 ml on average per day, we are going to save ourselves in formula cost and donor milk costs. We did not look at everything in this particular study. We did just look at those first 3 things, the pump, the kit, and the containers, and we did that intentionally so that we could say, okay, what is it just to get it in the door? We are now in the process of looking at some additional sources of cost that often come under scrutiny, things like fortifier, the lactation staff, the people who prepare the formula, if it's a specialty formula, space, and the environmental impact. And here's some of the things, some kind of brief highlights of what we are finding so far in this ongoing project. We find that having an industrial-sized freezer requires 14.5 square foot of space, so you can actually get 4 or 5 industrial freezers in a very small room and still be able to realize those benefits. Our lactation staff, we've been able to successfully use peer counselors, which are $15, $16 an hour type of workers, to increase our available patient contact time by being extenders to our RN IBCLCs, and that has really allowed us to maintain high levels of human milk at relatively inexpensive cost. We're also seeing some environmental impacts. Formula waste is heavier than waste from human milk, and with garbage you pay by the ounce, so things that are heavier do cost more, and we find that because when you crack open those liquid ready-to-feed bottles, they need to be used within the hour. And so with our preterm infants, if they're only getting 1 ml every 2 hours, you're opening up a new bottle for each feeding and you're throwing out the rest. And our nurses try to say, yay, anyone else need this type of formula so that it can be distributed and drawn with the syringe and go across multiple babies, but that's really not realistic as a policy to try and swap it around. So, really they draw up their 1cc and they throw it out, and that goes right into the trash, and it's a heavy weight. We also, interestingly enough, found that some of our policies that we had about how you dispose of syringes, certain size syringes have to go in the sharps container, other size syringes can go in the trash, and based on the syringes that our staff was using to feed infants, we were throwing a lot of feeding syringes into the sharps container, which is a much more expensive disposal cost than the trash would be. So it was an interesting way to find out about some of our own practices. From the actual formula cost, we we're very blessed or fortunate. Our utilization of formula is actually so low that we couldn't, in time for this presentation, figure out what the actual cost was. So instead I went out to the literature and looked at some of the work from Merwood and Phillips out in Boston, and they basically found that it was around $16,000 annually when they finally went baby friendly. And in talking to them, it hasn't particularly changed that much, although the costs have gone up because of that number was published in 1999, and it's almost 14 years later. So it is a little bit more expensive today, but it's still a pittance. That's a very small amount. Some of the other things we found is that if you look at the time to prepare formula, so if you're using formula, not all, especially if you have a preterm population, not all infants can use those standard available mixtures. They need specialty formula. It takes about 4.5 minutes to prepare a specialty formula for one infant. And considering that you have to do that every day, 7 days a week, 365 days a year, it basically turns out to be a person. And here it's one person because we have a low formula usage. At other hospitals it might be multiple people because they have a higher formula usage just to prepare the formula. And imagine if you invested those resources in a peer counselor instead, maybe not needing those additional bodies to prepare formula. We also wanted to see how often our formula reps spend on campus, and so we looked at fiscal year 2011, and we found that on average the formula reps are here about 1,500 minutes a year doing what they do, and so that's a low number, I think, but something to be aware of. So with that, I'm going to turn it over to my colleague, Dr. Noonan, and have her tell you about what it's been like in real life.
Hello, thank you for joining us today, and let me know if you can hear me okay. And I'm going to start our little experience here with our real-life journey with Baby Friendly. I've been in this position of the director of the Children's Hospital for just a little bit over a year, the beginning of March, and I was really shocked fairly early into my tenure here to discover that we had not declared for Baby Friendly, that we had not sent in the initial documentation to become a Baby Friendly hospital. And one of the first things I did was make that happen. Sent in our first, starting the first level of the journey, and then quickly moved on to the second level of the journey. So I think that there was a really good, actually I'm going to go ahead to the journey here. So this is a description of what the Baby Friendly journey looks like. So the first thing is to register. This discovery phase is really fairly simple and not very costly. It's getting a letter from your CEO. It's completing the self-appraisal tool. When we actually completed the self-appraisal tool, we were already more than 60% compliant with this. More than half of the measures that there's about 80 different indicators that you complete on your self-appraisal, and we were short about 30. So when I looked at that, I thought, well, really, we're doing so much of this. And, of course, as Brianna showed you with all of the work they've been doing in the NICU, we had made the case and made a case, for the country, really, on why it made sense to do this for preterm infants. My case was to prove why we wanted to do this for all infants. When you get past that discovery phase, you then go into the development phase. That's where you convene your workforce, your task force, start your work plan, craft your policy. When I'm a real nuts and bolts kind of person, so this pathway can sometimes look complicated to you, but basically here's the things you need to do. You need to change your policy. You need to do education, and that education is for nurses and all providers, physicians and nurse practitioners. It's for your expectant families. And it's for everybody outside of OB too, because this is the point. We can tend to become, in women's and children's, somewhat isolated from the rest of the acute care hospital. This is the point where you've got to bring the message out to absolutely everyone. The other main point is skin to skin. You've got to begin skin to skin, getting that baby skin to skin within the first hour. And that's another big hurdle. Lactation support is a fourth big hurdle, and that's about providing lactation support while women are pregnant, after they deliver, and after they're discharged. And again, outside of the OB department, because this is something you're going to have to provide lactation support for a woman who has a gallbladder surgery and is still breastfeeding an infant or a young child. So we really want to be able to provide that everywhere. I would say the fifth big hurdle is getting rid of pacifiers and formula or any feeding outside of human milk. That's a big hurdle. We have traditions that we've grown accustomed to that are not in the best interest of our children. The sixth big hurdle is what they call rooming in with breastfeeding on demand. And honestly, I object to the term rooming in, even though Baby Friendly uses it, because it's not rooming in. It is providing a mother-baby program of care. Because the baby is not in the nursery anymore and is in the patient's room, that does not mean that they do not receive the same level of care they would have received in the nursery. And that's what you need to guarantee. It's not just a matter of placing that baby in the room with mom. It is making sure that 24 hours a day that that baby is receiving the same level of care they would have received in a nursery. Only, you know what, it's exponentially better because their parents and other family members are involved in that care. So you've got to build, if we look at our care that we provide in the hospital for families, it's that we should be building their confidence in their caretaking abilities. So often one of the complaints nurses have, or physicians have, or patients have learned traditionally is we've told them that we need to whisk the baby away if the baby's crying because the baby's interfering with their sleep. I would say to you, I would challenge you with that and say, isn't it our job to build the confidence of that family in being able to take care of a crying baby in the middle of the night? So it's a real shift in our culture. The next biggest barrier is that international code of marketing of breast milk, which has been known as the code. It means that we're going to pay fair market value for formula. I would also encourage you to look at that as, if you look at your corporate compliance policies, you need to be paying for fair market value for formula to meet those corporate compliance measures. Keeping all formula and anything about formula out of sight of the families, that can be a little challenging, but it mainly means, changing around some of where you store materials. And then one of the biggest barriers is those free packs. Everybody feels terrible that they can't give the families those cute little diaper bags or those cute little bags that have the ice packs in them and the containers for milk, and all of the cooler, all the formula companies have been incredibly inventive in keeping those packs in a way that make us want to give them to families and feel like we're cheating families if we don't. You also have some families that received it last visit, and so they're saying, what happened? How come I'm not getting that? So that, again, is about messaging. I would say, so a lot of these things happen in this development phase. It's probably your biggest and most challenging part of your journey, this development phase. It's also where you start your data collection plan, all the data that needs to be collected as part of Baby Friendly. But I'll tell you, the biggest benefit of sending in that $3,000 check is that you become a member of the Baby Friendly Initiative listserv. I have to say it is almost to a point of being annoying, the most active listserv I have ever participated in my entire career. There are multiple postings every single day, but I have to tell you that there's no question that any member of your staff could have that isn't somewhere on that listserv and has been answered in a very professional and evidence-based way. So it's well worth the sign up to do it. Your dissemination phase is when you train your staff, you collect data. Your designation, you're getting ready to have your on-site assessment, and then hopefully you're moving on to your baby-friendly designation. This is, I like, because I come from an educational preparation that prepared me for a logic model, I kind of like the logic model, but I also like the way that it really itemizes the different things that you're going to need to do baby-friendly. So aside from my kind of cheat sheet list of policy, education, skin-to-skin, lactation support, no pacifiers and formula, rooming in, and the international code, I think that this gives you a good way of how do you make each of those markers along the path that they provide for you. So these are the 10 steps to baby-friendly, which have been shared already with you by Brianna, but it gives you some more detail about what you are doing on your path. Now, one of the things that was the biggest barrier in our organization, surprisingly, because we had already made the shift to fair market value for formula, we had already made many shifts. Skin-to-skin was already being done, was the education and the concept that we needed to do education and the number of hours of education that needed to be provided for nursing staff was, I would say, the first barrier I encountered. What we did is we took the baby-friendly nursing curriculum and we looked at it, and they allow you to do this. We looked at it in comparison to education we had already been doing, and we were already meeting the majority of that education. So the concept that we were going to have to spend hundreds of thousands of dollars training our staff was inaccurate because we had already met a lot of the educational criteria. And I do challenge you that I think if you look at your organizations, you may have met more of that educational criteria than you thought you did. So these are the this is the baby-friendly fee schedule. So these are just the fees. This doesn't take into consideration all the education that goes along with providing it. It doesn't take into consideration the cost that you derive from having a breastfeeding committee or a baby-friendly task force that is meeting on a regular basis. We always forget how much meetings cost us, but you have the average salary of everybody in that room that is the cost of that. Preparing the educational curriculum for baby-friendly as well as for the skin-to-skin, for the lactation support, for the true mother-baby concept of program of care. All of that education does account for a lot of dollars, but in the long run, they're dollars well spent. So that is not included in these fees. The other part that's not included in the fees is for your designation, you will have you'll have the cost of bringing the assessors out here. Now, some of you may be aware, others may not. The way the assessment is done is that your staff is asked questions, your patients are asked questions. So it's not a matter of you can just show a lot of data. They need to see that they can ask the questions of your staff, of your patients, of your physicians, that they understand what is entailed in baby-friendly, and that they can say to you, yes, I did provide the education to this mother and father or other family members, whoever the person is that's supporting the mother. They have to be able to articulate all of that. So it's not a matter of just being able to do the education, do a pre-post test, all that sort of thing. You really have to live it for that designation phase, or for, yeah, the designation phase for when the assessors come out, because that is how they do the assessment. But I believe the results are priceless. These are some photographs of skin to skin, even the kangaroo care with a preterm baby in the lower right-hand corner. So while there are costs involved, I kind of think about this like magnet. You know, the magnet designation for nursing excellence. Organizations are beginning to stand out if they don't have the magnet designation. Used to be, there was a point where it was you stood out if you had the magnet designation. We're reaching a tipping point where you're going to stand out if you don't have the magnet designation. I believe the same thing is happening. I'm watching the curve of organizations that are getting this designation, and or at least declaring the designation, the path to the designation, and it's going to be like that. We're reaching a tipping point. It's no longer that you're distinguishing your organization by being baby friendly. You are giving a negative distinction of your organization by not going baby friendly. So as I described before, there are tangible costs. There are costs of all that training. Policy development takes time. Implementation takes even more time. There are public information sheets that need to be developed. You do still have formula costs because there are still fortifiers and things you have to have for even human milk. Freezers and refrigerators, we provide them in each of the rooms. That's a cost. And then once you put a refrigerator anywhere, you also have to monitor that refrigerator. And peer counselors, which is also optional, but it's a nice cost-effective way to provide additional support to kind of extend the capabilities of your lactation consultants. Another one I'm very aware of because of my years in practice is that, you know, we've gone through several iterations of believing that we needed, and I speak as an administrator, providing lactation consultants, and then some hospitals have gone back and said, no, we need to ensure the competencies of our bedside nurses. Will have less lactation consultants. That balance between the knowledge and support of the bedside nurse and the additional support of lactation consultants is a balance that every institution needs to come to. You need the balance. Your bedside nurse needs to feel confident in increasing the competency of the family and needs to be able to call on lactation consultants when it goes beyond their capability, as opposed to calling on the lactation consultants for everything. And that's a balance that has costs involved in it. And then, of course, there's the intangible costs, changing staff behaviors. You're really doing a cultural change. I always like to refer people, I think the best thing we could all look at today to remind us of what supporting families was supposed to look like is that WTTW television show, the public television show called The Midwife. Now, as an ex-labor and delivery nurse, I'm not going to advocate for all home births, but I do have to say we have to go back and look at that to say, what is it we do to support a family? We institutionalized the process, and in that we took away human milk, which is so important for our babies. So I think we need to go back and re-look at why we do some of the things that we do. Is it in support of the family, or is it in support of the way we deliver care in the 21st century? And we need to question all of the work that we do in that manner. And then brand value. As I said, you run the risk of being the hospital that's not baby friendly. Thank you. I would like to open up to questions now.
And as I said before, you can ask questions by clicking the button on your control panel to raise your hand. We'll call on you, and if you could please, when we call on you, we'll unmute you. If you could give your name and where you are from, that would be great. You can also, of course, type in your questions via the questions panel on your control panel.
Dr. Noonan, this is Beth Seidel.
Hi,
and
Beth.
that was fabulous. Thank you so much. I do have a question about the training that you found that you were able to count towards your training requirement. You said that you looked at education that you'd already been providing. Can you tell us a little bit about how you were providing that through like skills days, or how exactly you were already doing that?
Okay. We were actually already requiring a breastfeeding competency from all of our nursing staff. We were already including in orientation, spending a day with a lactation consultant, actually doing observations and assisting patients that were having difficulty breastfeeding. We had, I don't have all of that in front of me, I'm sorry, but there were, when I put the curriculum side by side with the things that we were teaching, we in orientation do an 8-hour education, didactic education, in addition to the 8-hour of hands-on following the lactation consultant. So as we went through each of the competencies that they expected in Baby Friendly, like I said, we were meeting the majority of them.
So have you come up with some kind of a tracking record for that? It sounds to me like it would be great for the people who are listening to this webinar. Their brains might be kind of ticking right now thinking, wow, maybe we should start tracking the topics that we're covering in orientation, and when the staff member is following somebody from the lactation department, do you have some kind of a tool where they track, okay, today we learned about supplementation using a cup, or do you have any kind of a tool that you guys use to track that?
I can share the gap analysis that we did, and tracking the education is done on the individual basis with the nurses as part of their skills checklist and orientation and part of their competency, but I'm willing to share any of that information too.
That would be great, because as you found, and a lot of the folks who are working towards Baby Friendly now, they are finding that staff training is one of the biggest challenges. It's also one of the bigger expenses that they have to look at. So yeah, that would be great if you would be willing to share that. I bet there would be a lot of people who would be happy to see how you're tracking that and what you're doing there.
Okay, that would be fine. I also, I challenge that why do we let staff training, let's say Joint Commission came up with a new, what is it they're called again? Not a competency, what?
A core measure?
Core measure. Let's say they came up, well, and they have core measures around this, but we somehow always find the dollars for training to make sure that we're in compliance with Joint Commission, IDPH. If we've had a quality issue, we go back and retrain staff on this, that, or the other thing that was part of that quality review that we did over a case or something. We always manage magnet requirements. We always manage to find the dollars for that. So I really challenge pushing back on it and saying, but this is just as important. And that was, frankly, where we had been hung up in going to the next phase, had been on those education dollars. And I challenged the group not to be hung up on it. I challenged the group to the task force to do the gap analysis. How many hours were we really looking at? And building that, how could we afford to do that? What was the real cost of doing that? And honestly, you know, when they presented it in nursing finance and to the chief nursing officer, this was not a barrier from their side at all. We had made it a barrier.
Thank you so much for sharing that experience. And another thing I wonder if you could speak to, I know that in the baby-friendly hospital that I work at, we have certainly found, and you alluded to this when you said that the bedside nurse needs to feel confident in helping the mom with breastfeeding, that our patient satisfaction scores went up at the time that we trained everyone because of that bedside nurse who was more confident in helping with breastfeeding. And in addition to that, the consistency of education really provided across the board. Could you speak to that at all? Sure.
I think that you find it's like with any training, you know, you're going to have 20% of your staff, they're the gold star staff, they're very comfortable, do a great job. Then you've got about 60% that are somewhere in the middle, either leaning towards the top or the bottom, and you've got 20% who it seems like they're very difficult to get them comfortable with it. They just can't get comfortable with it for some reason or another. And they provide the most support. So, I mean, they are needing the most support from the lactation consultant. So I think you see varying degrees of confidence on the nurse's side, but I think you have to keep working through it and working with people to understand how important it is to provide that support at the bedside and not just go running for the lactation consultant. Brianna wanted to say something too.
You know, I think one of the other training ones that we found when the Milk Club program first came in is that you got to engage the whole staff. It's really important not to leave out. Like, I remember reading a comment from a patient comment card one time about the housekeeper piped up and said something about her breastfeeding experience or his wife's breastfeeding experience, and it was including them in that conversation and having them feel comfortable, you know, saying something to the nurse or saying something to the lactation consultant as well if they saw something that was a danger sign or, you know, where a family really seemed to be struggling and wasn't reaching out for help. So it's everybody's on the team together, not just our docs or, you know, our nurse practitioners. It's everybody, and they're all committed, and that's that part of, you know, kind of, you know, going to them and saying, we want you to be part of the team too. All of a sudden now we've got, you know, a bunch of more eyes and ears that are part of that process.
Right. When you think about the Joint Commission analogy, you know, Joint Commission, we all know, can walk in the building and can ask anybody about race and past, you know, the fire training. So we do it consistently everywhere to make sure everybody understands that. How is breastfeeding less important than that? The likelihood of having a fire is very, very low, but the need for breastfeeding support is very, very high. So shouldn't we put the same sort of effort into it?
That is such a great point. And I think that the other thing that you said that I really appreciated is that we are moving to a time where if you aren't baby friendly, you're going to stand out in the crowd. And you know, certainly as the consumer who is seeking a hospital with good breastfeeding support seeks out where she is going to deliver and making that choice, you don't want to be the hospital that stands out as not being baby friendly. And on that same vein, you know, how can we not think that training our staff on supporting baby friendly is important, that you don't want to stand out as a facility whose staff is not well trained in that. So I just really loved your wisdom on that. Thank you very much.
Thank you. And I think the society, if you even watch television and things, you're not seeing bottles like you used to. it's an expectation if they show a birth that they're putting the baby skin to skin. So hopefully more and more television shows and other media areas will keep showing women and families that this is the way it's done, that it's not something you have to request or you have to shop around for. This is the standard.
Okay, I'm going to ask one final last call for any questions. If you have questions, you can type them into the questions field and submit them, or you can raise your hand by clicking on that button in the GoToWebinar control panel.
And Billy, if there aren't any other questions, I have a couple more, but I certainly don't want to keep anybody else from asking. This is Beth again.
Oh, go for it.
But I have a question for Brianna. It's a NICU question. How do you convince the moms who may not have been planning to breastfeed to pump for their babies?
Oh, sure. That's actually a really great question, and we have a paper on it. It was written by Dr. Donna Miracle. She actually, at one point in time, was the director for the Indiana Human Milk Bank. She was a doctoral student here. I think she's now with Cadence Health. But, you know, we have about 50% of our women who come in who didn't think they wanted to breastfeed, especially among some of our minority populations where breastfeeding isn't as normal or as frequent and likely as it is among some of our Caucasian populations. And one of the things we use, our peer counselors are women who have been through that journey. They are mothers who were from the NICU, and they share that personal connection with our women who, you know, are going through the journey of having, you know, pregnancy that they might have fought for that ends too soon, and now, you know, they're looking at not that bouncing baby, but that baby who might have a lot of needs or who might not make it at all. And it's pretty hard to then all of a sudden be willing to entertain the idea that, oh, now you want me to provide your breast milk. So it starts, our peer counselors, our doctors, our nurses. One, they're all given the same message, and they walk in the room with the idea that that mom is going to breastfeed. We're going to educate. I remember we have milk club meetings every Friday, and one of the mothers who delivered at hospital and was then transferred to us, her baby was transferred to us. She was not told about human milk at all. In fact, you know, it was just assumed that she wouldn't even bother. Nobody brought the topic up. They figured, oh, she's a young woman, and she was a woman of she was not a white woman. I don't remember what her racial identity was, but, you know, she was totally brushed off. It wasn't even brought up, and she was just hot, spitting mad in that meeting because she felt insulted. So that it wasn't even she wasn't even talked about it. So we go in with the expectation that this is what's best for your baby. Milk is a medicine for your baby in those early periods, particularly. We also work with mom to meet her where she is. So we set a breastfeeding goal. Maybe she doesn't ever want to put that baby to breast ever. That's okay. We're not gonna, you know, we might still give her what the benefits are of putting the baby to breast, you know, so she knows, so she is well informed. I mean, it's our job as a healthcare provider to give her that education. But if she, after hearing that education, says, you know what, I never want to put my baby to breast, it's gross, it's icky, I don't like it, I don't want anybody up in that area, we respect that. That's fine. Then let me help you be the best pumper you can be. And you know, or the mom who's like, I just want to do a month. Okay, great. Get you started. Let's talk about it in a month, because a lot of those women who are like, fine, I'll do it, but I only want to do it for this long, they go on to be the exclusive breastfeeders that put them to breast because they see the value. We also have a dad who's a peer counselor, and in many instances having that male voice in the room and having dads have their own meeting can be very helpful, because all of a sudden now mom's got a really good supporter. We have a grandma as well who can, kind of send that message and say, no, you know what, this is her only job right now. She's gonna provide milk for that baby, because we see the difference, and we talk science. I mean, we have some of our moms have very low literacy. We're telling them about stem cells and breast milk and, these really complicated, Paula does a great job of bringing these really complicated topics and research around human milk and bringing it down to a level they can understand it without being condescending, and really making them part of that process. And you'd be surprised, once they get that education, it's just telling the truth, giving them the story, and being absolutely resolute and believing that they can do it, even if they don't believe they can do it, because they've got to have somebody who has faith in them, and we're that faith.
I have another question, Brianna, along that same vein. I noticed on your graph that you did have some moms who were pumping less than 100 mils a day, and I would imagine that some of the babies in the NICU, the moms had a history of infertility, and very often we see milk supply issues with those moms. Can you speak at all to how you boost the confidence of that mother who is only able to pump a couple of ounces, if even that, for her baby a day?
Yes, we actually, for those moms in particular, we go back and we look at, what that means and how long that milk's going to last. And we really, even those women who were in that less than 100 milliliter a day, their babies were still, on average, exclusively human milk fed for the first month in the NICU stay. And that first month is critical, because that's all that risk for neck and sepsis and, some of the preventable brain injury things. That's all in those first 28 days. And if you can have exclusive human milk in that period, or at least that's the highest risk time, you've battled the battle. You're getting there. So even though, yes, it's frustrating and it's not what you wanted, just that little bit, it goes a long way, particularly for those littler infants. We also bring in some examples from Paula Stick's group and Richard Sandler's group down in Texas that shows that, every 10 cc's helps. Every 10 cc's reduces your risk for a lot of these things by a percentage point or more sometimes. So, we don't make it about the volume. We make it about how it's going to work and how it's going to help her baby. I can think of one woman in our study who, I don't think she pumped more than 50 mLs a day, and she pumped for months. I mean, months. And she never really got there. She just didn't. We also, with our peer counselors, because they are preterm moms, if they see a woman with those milk logs who's struggling in that way, they're the ones that go right to the highest level of lactation support we have to see, is there something physically wrong? Is there a hormone issue? Is there, one woman they found did not, they actually determined her placenta hadn't fully detached. There was a real medical issue, which was why she wasn't producing milk. So we treat it with the appropriate concern, and sometimes it is just, that's what it is, and other times there's something medically there that needs to be addressed and maybe hasn't been in the past. So we make sure we give that support both ways, and we don't give the message, oh, well, you just can't do it, or you've failed. It really is, we're going to work with you on this journey, and if that's the answer, then you know what, it doesn't matter, because it's still helping your baby, and we're going to help you do, that's the #1 priority.
Okay, I have a question here from Teresa Schultz, and she asks, how do you introduce moms to the initial skin-to-skin experience? Does the conversation start in the OB office? At admission, is handout and discussion made regarding skin-to-skin and essentials for breastfeeding experience?
All of the above. It is introduced prenatally by the obstetricians. It is introduced during their labor by the bedside nurses. We do have handouts about why it's important, and we do have handouts about why it's important to feed your babies human milk. And then we make sure, and those handouts describe, oh, it's also in our prenatal classes, sorry. And we also make sure that they know that they will have support.
Okay, and then we have a follow-up question. Are your peer counselors from WIC or identified from past patients?
That's a great question. Most of them are identified as our past patients, so they actually had a baby in our NICU, but not all. You know, we have someone who was a term mother, and that I think might have come from a referral from one of our peer counselors. Our peer counselors go and work with the WIC agencies as well. We have a specific grant that is in that. In fact, we have some materials that WIC agencies through that grant are eligible to receive for free, some educational materials, videos, those types of things that they can incorporate into their lactation programs that they offer. So it's most of them are past patients, but not all. Some have come through other referrals, but a lot of them are women we know through some means. They've been involved with our milk club in some way, because those just tend to be the people that apply. I'm sure if someone else applied, we would consider them, but it just hasn't happened.
The other thing is you just have to have this overall philosophy that you will succeed in breastfeeding. I mean, I think that it's an overall philosophy that you need to share with your patients and your prospective patients, that we do believe, you know, our belief is you're going to succeed. I think too often the message out there is, oh, I tried breastfeeding, it didn't work for me, and they get a message of it might be impossible, and that having difficulties is normal, where we want to give them the message that succeeding at breastfeeding is normal.
Okay, are there any other questions? You can raise your hand or send it via text.
I have another question, Billy, if there's nobody in the queue waiting.
Go ahead.
This is probably for Dr. Noonan, but when you talked about rooming in and that you just really look at that differently than rooming in, how do you respond to the mother who is requesting her baby be taken to the nursery in the middle of the night?
Well, first it's to find out why. Why is she requesting it? And is it because from previous pregnancies she's been given the idea that, or previous births, that she's been given the idea that she's not going to be able to rest unless the baby is in the nursery? And then I re-educate on how mother-infant contact actually increases the baby's comfort, and the baby's more likely to sleep if the baby is with her versus in a nursery. So that she's kind of defeating her purpose, that if we send the baby to the nursery, the baby's more likely to become uncomfortable, and ultimately the baby's going to end up back with her. So why not have the baby more in tune to her and more comforted by her presence than by her absence?
And do you do education prenatally with moms about expecting to room in when they come to your hospital?
Yes.
In the same way that you do the skin-to-skin, like through class and handouts and such?
Yes.
Okay.
And actually, you know, most of our practices here are we have a good relationship with those practices, and we're able to give them materials. And they're, you know, with the people in the practices, and I hear people say, oh yeah, fine, you know, you have a bunch of owned practices, you can make people do things differently. No, not so much. I mean, you can have independent practices, private practices, and those people that work in that practice, not just the physicians, but the greeter at the front desk, everybody in that practice, they want to be very aware of what's going to happen. They want to be in the know. And so materials that you can get to them about what this experience is going to be for for their patients is very important. I think we underestimate how much people that work in the private practices or in the practices influence our patients, and that's an audience you've got to get to.
Thank you.
Thank you very much. It seems that there are no other questions. I do want to mention that this webinar has been recorded and will be posted sometime within the next week or so to illinoisaap.org. So if you want to revisit it or if you want to share it with colleagues who couldn't attend the live presentation, that will be available. We'll also try to send an email out to everyone who is on this webinar as an attendee to let you know when that happens. Thank you very much for joining us. I'll turn it over to Beth one more time.
I'd like to thank everyone for joining us today. We are going to be sponsoring another webinar definitely in July, and we'll be sending some information out about that. And then we are anticipating one about mid-June as well. And we'll let you know. But if you have any topics of interest that you would like us to provide education on, we would appreciate any feedback that you might want to share with us on that. But thank you very much to our speakers, Dr. Yeager and Dr. Noonan, and we appreciate you taking the time.
Thank you all very much.
Thank you.